Good morning, everyone, and welcome to Rice University and the Baker Institute for our conference on National Healthcare Reform, Policy Options, and Imperatives. Thanks very much for taking time out of your busy schedules to be here and join us today. My name is Vivian Ho, and I hold the Baker Institute Chair in Health Economics at Rice University. I'm also an associate professor in the economics department here at Rice and an associate professor in the Department of Medicine at Baylor College of Medicine. Many members of the audience are regular attendees of our events here at the Baker Institute, but in organizing this event, we actually really wanted to attract parties who are interested in national healthcare reform from all different sides, including clinicians, insurers, healthcare administrators, and people involved in healthcare financial management. So for many of you, this is actually your first time here at a Baker Institute event. Because of that, I'd like to take a minute and tell you about our organization. The James A. Baker Institute, the third for Public Policy, was founded 14 years ago, and its mission is to bridge the gap between the theory and practice of public policy. So the Institute draws together experts from academia, government, the media, business, and non-governmental organizations. And we have a joint effort to understand and address the underlying forces shaping our world. Now, since its founding, the Baker Institute has been fortunate to welcome a number of distinguished speakers from around the world. These include Nelson Mandela, Shimon Peres, Madeleine Albright, and most recently, a couple of weeks ago, Bill Clinton. We're a nonpartisan organization, and we make a serious effort to get all the relevant ideas out on the table and to hear a diversity of views on important policy issues like we're doing today. We're led by Edward Derejian, our founding director, and a former ambassador to both Syria and Israel under the previous two presidential administrations. We're also grateful to have former Secretary of State and Treasury, James Baker, serve as our honorary chair. He visits often. He plays an active role in bringing top quality speakers to the Baker Institute. The Baker Institute seeks out fellows and scholars to study a range of issues that shape our world today. So some of the other fields that we're involved in are, for example, terrorism. We've studied the consequences of the war on terrorism for both domestic and foreign policy. In addition, the Baker Institute Homeland Security and Terrorism Program assists the Houston and Harris County region in continual assessment of the security posture of our particular region and informed discourse with public officials and public education. We also are interested in the Mideast diplomacy. Secretary Baker co-chaired the Iraq Study Group, and Ambassador Derejian served as a senior advisor to the ISG. We also have a diverse program in energy at the Baker Institute. This is led by Amy Jaffe, and its program studies issues ranging from nanotechnology and energy to the geopolitics of gas to cultural, religious, and social factors that influence world energy supply. We also focus on science and technology, and this program, led by Neil Lane, hosts a series of conferences that have advanced the dialogue between scientists and policymakers around the world regarding policies towards stem cell research. Now, our conference today has been organized by the Baker Institute's Health Economics program, which was launched in 2004, and the Health Policy Forum, which we just initiated last month. I direct both of these programs, and the mission of the program is to study the ways in which economic incentives and government policies influence the quality and cost of healthcare. And the program's guiding philosophy is that society can deliver high-quality healthcare while controlling expenditures. Now, we're a small but growing program, and since our inception, we've been conducting research on a range of issues, including the costs and benefits to patients of increased competition among hospitals for complex cancer surgery, the consequences of state regulations on cardiac surgery, and the connection between physician supply and regional differences in health disparities. Our research has been featured nationally by the New York Times as well as locally in the Houston Business Journal. In March 2006, we were fortunate to have Leon Leach, Executive Vice President and Chief Business Officer at the University of Texas MD Anderson Cancer Center, join the Baker Institute as the Sid Richardson Visiting Scholar in Health Economics. And Mr. Leach collaborated with us in our ongoing research program on the economics of healthcare for the indigent. Mr. Leach is also working with the Baker Institute Science and Technology program and its initiative on stem cell research. So before we proceed with our speakers, I've asked Mr. Leach to provide you with some context for today's discussion. Mr. Leach.
Vivian, thank you very much for such a kind introduction, and thank you for having me back to the Baker Institute for this important event. Let me start by reminding you of the nation's current situation with respect to health care, not that anyone in this room is going to need any real reminders. The U.S. currently spends more than $2 trillion, or approximately 16% of our gross domestic product, on health care. This spending has established us as the world leader in the development of advanced medical technologies that cure diseases, but this progress has come at a price. For most of the last 40 years, rates of growth in spending on healthcare have exceeded growth rates for the entire economy. Much of this spending is financed by employer-provided health insurance. As health insurance costs have risen, so have health insurance premiums, which are commonly shared by the employer and the employees both. Employers argue that these higher premiums or higher costs impede their ability to compete globally with foreign companies that have lower labor costs. Employees suffer as they see their wage increases eaten up by insurance premiums. At the same time, 42.4 Americans reported that they did not have health insurance in 2006. Many of these individuals are in families where the workers have been priced out of the insurance market. The rising healthcare costs have led many small employers and self-employed workers to forego health insurance. Uninsurance has been linked with a lack of access to preventative care. It's been linked to financial bankruptcy, personal financial bankruptcy, and even premature death. Moreover, much of these costs of healthcare for the uninsured are borne by everyone in the local economy. This is especially true in our local community. Hospitals in the Texas Medical Center and around the city are burdened with hundreds of millions of dollars in uncompensated charity care each year. We face unprecedented crowding in emergency room departments as uninsured patients are forced to use our ERs for a whole host of medical conditions not typically best treated in the emergency room. And Houston's not unique in that regard. Ken Thorpe, who will speak later today, estimated that health insurance premiums for the Texas families were $1,551 higher in 2005 due to the unreimbursed cost of health care for the uninsured in the state. That's significant. The combination of uncontrollable cost and rising uninsurance has led to a flurry of proposed and actual health care reforms over the past year. Massachusetts has implemented a program for universal health insurance coverage. California and Pennsylvania have proposed their own programs. The Healthcare Coalition for the Uninsured has issued a bold plan to expand insurance coverage that will cost $60 billion over 5 years. President Bush has called for reforms that will give all Americans a tax break for buying insurance while reducing the current tax incentives for the overconsumption of health care. And of course, health care reform is at the top of the list of proposals for all the 2008 presidential candidates. We are very fortunate to have a number of outstanding speakers this morning and this afternoon who are listed in your program and who will help us understand the challenges of national health care reform. We have not asked them to comment specifically on any particular recent proposal for reform, although you may find them doing so in the course of their talks or certainly in the question and answers that will follow. Instead, we have asked our speakers to focus more broadly on issues that are essential to the success of any healthcare reform that will expand access to high-quality health care in the United States at an affordable price. Each speaker will present their ideas to you in 40 minutes, leaving 20 minutes afterwards for questions from the audience. We want this to be an open forum for everyone who is interested in the topic, including healthcare providers, policymakers, consumers, and students. And I've seen all of those categories walk in today, so that's great. We're encouraged by that. The PowerPoint slides from each speaker's presentation, as well as a brief summary from each speaker, will be posted on the Baker Institute website after today's conference. These materials will form the basis for a new section on our website that will also track new proposals for healthcare reform and provide objective critiques by informed healthcare policy experts. The economist, health economics program at Baker Institute is grateful for the Sid W. Richardson Foundation's generous support of its research program in today's conference. The goal of the program is to make this conference a biennial event, which will continue to track the progress of national health care reform and inform the community on its implications for Houston and for the country as a whole. So to get things moving, I'd like to turn the podium back over to Vivian, who will introduce our first speaker. Thank you.
We're just going to jump right in with our first speaker, who is Dr. Kenneth Thorpe from Emory University. When you walked in, you should have received a program which has an extensive biography on each one of our speakers. As you see, they're quite a talented and experienced group. So I won't be reading the bios verbatim to you. Dr. Kenneth Thorpe is a chaired professor at Emory University. And he has advised past presidential administrations on their various different healthcare policies. He's widely respected by academics for his innovative ideas, and most lately about chronic disease, and I hope you might talk about some of those today, Dr. Thorpe. But he's also sought after by past presidential candidates and current presidential candidates for his advice on healthcare policies. And so with that, I'd like you to start the day off.
Well, good morning. Vivian, thank you for that kind introduction. And I must say, I've been to Houston several times. I've never been to Rice. Congratulations on this wonderful program, beautiful building, beautiful school, and I wish you all the best of luck with it. It's quite an impressive place, so you should all be proud of it, and I know that you are. As you heard, we're going to be talking about some of the high-order issues in the healthcare reform debate today. I'm going to be talking about healthcare spending and what my take on why I think expenditures are rising over time. That's what I'm going to be talking about. What I will not be talking about are some of the other health policy issues that really are dominating the public airwaves and public attention. So I will not be talking about, for example, whether Barry Bonds is on steroids. I will not be addressing the issue of whether or not there are evidence-based protocols to deal with the variety of ills facing Britney Spears. I also will not be talking about whether there's definitive evidence on who actually is the father of Anna Nicole's baby. So those are not on the agenda today. Healthcare spending is. Start out with an overview. And these are sort of, I think, the high-order takeaway points of what I'll be talking about today. And I start with this because for whether you're a governor or whether you're a policy director at a health plan or whether you're a presidential candidate looking at this issue, I think if we're going to deal with the issue of affordability and getting the best value for healthcare, I think it's really critically important to understand what's driving the growth, what are the underlying forces that we need to attack, and where we're spending our money. Because as you can see from my first point, I don't think we can really craft effective interventions until we really have a clear diagnosis of what's driving expenditure increases up. The 4 points I usually start out with is, one is about 3/4 of what we spend on healthcare is associated with patients that have a chronic disease, and it's usually in individuals that have multiple chronic illnesses. And we'll talk about what's going on with that. 2 is that we don't do a very good job of providing healthcare services to chronically ill patients. They get about 56% of the clinically indicated preventive healthcare services. It's not in this case that we don't know what these services are. It's just that our delivery model in the United States and the way we pay for healthcare services is really not geared to provide the range of primary preventive services to chronically ill patients. The 3rd point is that the rise in what I call the prevalence of treated disease accounts for a substantial share, roughly about 2/3 of the growth in healthcare spending over the last 20 years. And we'll talk about what's going on with that. And the 4th point is that the United States now has 1 in 3 adults that are obese. I'm glad I'm doing this talk in the morning, not after lunch. But perhaps it'll direct some of your lunchtime choices. The doubling of obesity over the last 20 years, in our estimates, is responsible for about 30% of the rise in healthcare spending. Now, the interesting thing about these facts collectively is that if you look at attacking this issue in terms of new policy interventions and levers, most of the trigger points really focusing on more effective management of where we spend our healthcare dollar, which is on chronic illness. And also, it really does point to issues with respect to primary care and primary prevention, dealing with the obesity issue and trying to come up with effective ways to change behavior in ways that we haven't done in the past. What's really off the table, I think, is going to fundamentally reshape the issues on healthcare spending increases, is issues with respect to benefit design, copays, deductibles, and so on. It's not to say that consumer-driven plans and copays and deductibles and benefit design is not important, and that definitely needs to be part of the policy mix. But I think the data I'm going to show you here is really focusing on a broader set of policy tools that we need to consider in dealing with the issue of affordability and rising healthcare costs. One of the things I think that's sort of important to understand what's going on in the healthcare economy is that as the clinical characteristics of patients have continued to change over time, and they have changed very radically over the last 20 or 25 years, away from episodic acute care types of cases now to chronically ill patients with multiple conditions, has had an important impact on the distribution of spending within the healthcare economy. In 1987, about 45% of healthcare spending was associated with hospital care. Today, that's down to about 36%. Prescription drugs, obviously, over time, continue to play a bigger and bigger role, not largely because of rising prices of branded drugs, certainly that's part of it, but rather because we've had a dramatic increase in the number of prescriptions written per capita to try to provide innovative new treatments for patients with chronic disease. What we've been doing on this issue of healthcare expenditure increases is try to take a little bit of a different cut at this. I got a little frustrated looking at the data repeatedly over time. We knew sort of every year from the actuaries at CMS and Medicare and Medicaid report to us where we spend our healthcare dollar. How much of an increase this year did we spend on hospitals? How much more did we spend on prescription drugs? How much more did we spend on physicians? And those data get wide play. They're reported every year. But missing from that is what's going on? Why is it going up? What's underneath these channels of distribution of where we spend the dollars? And what are the underlying forces that are driving this up? I also thought it was important because absent any type of underlying analysis of these trends, the data that are displayed to policymakers lead them to policy interventions that may not be particularly well-meaning or effective. So, for example, if you see an explosion in spending on prescription drugs, and that's the only data information you have, that might lead people to say, well, geez, we need to control the prescription drug budget. We've got to do something about that, or we need to control the hospital spending budget. So you're led to, I think, interventions that aren't particularly effective and don't really deal with the underlying issues that are driving these expenditures up. So what we did is took a step back and say, well, this is really, in a sense, pretty simple. If you think about changes in spending, it's really three things going on here. One is that we're spending more because there's a change in the number of cases that were treated, so the change in treated disease prevalence. There's a change in spending per treated case, and there's interactions between these two as well. And a lot of the work that we've been doing over the last several years has been trying to decompose spending increases over time into each of these three buckets. The prevalence increases, as I've already told you, which are the dominant factor accounting for rising costs, there's really several factors that could generate increases in treated disease prevalence. Some are good. So we want to figure out how much of the rise in treated disease prevalence is due to good things, and how much of it is due to things that aren't good, that we can go in and prevent and perhaps develop policy interventions to treat. The first reason why disease prevalence trends rise over time is because of the rise in the incidence, the true clinical incidence and prevalence of disease. And this is true, for example, with diabetes, where total diabetes rates in this country over the last 15, 20 years have increased 60, 70%. And that's a true clinical increase in diabetes prevalence in the population after you age adjust and do the usual things to the data. Much of that increase, and virtually all the increase in diabetes prevalence, for example, is linked to the doubling of obesity. Technology, well, you'll hear later on in the day about a value in technology. Obviously, as we bring new innovation on the marketplace that allows us to treat more people, provide medical interventions for patients that we could not medically treat some time ago. The data you'll see that are probably most notable here on this front are treatment of mental disorders and depression. That 20 years ago we largely relied on cognitive interventions that are now broadening the medical opportunities to treat patients therapeutically in ways that we didn't have the opportunity to do so some time ago. Whether that's good or bad, we'll debate later on in the day. This third one I think is a very interesting one that I'll give you some data on. We've also developed new definitions of disease over time. One of the more notable ones in cardiology is metabolic syndrome. And as that disease has been labeled, new approaches for intervening for patients that aren't yet diabetic, aren't yet hypertensive, really more aggressive primary prevention have seeped up over time. So we've changed our clinical thresholds for treating patients that are asymptomatic, that aren't yet showing symptoms of disease. Whether that's worth it or not, again, is going to be a point that the data will speak to. We do a better job of detecting disease, so this is probably a good thing. Different forms of prostate cancer screening, breast cancer screening, certainly the recognition and diagnosis of depression all fall into this bucket. We live longer. So as you live longer, the likelihood that we're going to pick up a medical condition over time is also in play here. So the second part of our research agenda is really trying to sort out how much of the rise in the prevalence of treated disease is associated with each of these different categories. So we can try to figure out what the opportunities are for effectively intervening to get treatment rates down to levels that are perhaps more appropriate. These are data on starting with the obesity side that you've all seen. Just to give you a sense of scale here, about 1 in 3 adults are clinically obese. This varies dramatically by race and ethnicity. It varies dramatically by state. It also is substantially higher than what you see in Europe or Canada. The European average is about 17%. It is one of the contributing factors with respect to why we spend more on healthcare here than we spend in Europe. We're also more aggressively treating patients that are obese today compared to 15 years ago. This is the share of obese and morbidly obese adults that are receiving medical interventions for 6 or more conditions during the year. You can see in 1987 that about 9% of obese patients were under medical management for 6 or more conditions. That's doubled. The same is true for patients that are morbidly obese. 1 in 4 patients that have a BMI of 40 and above are being treated for 6 or more conditions during the year. So not only are we getting more and more individuals moving up the weight distribution, we're more aggressively intervening in treating these patients over time, in part because the opportunities and the technologies are evolving to give us a broader set of tools to treat, and there's evolving clinical thresholds and information about how aggressively we should medically intervene. Just to give you sort of an understanding of why these treated prevalence rates are rising, this is looking at standardized disease prevalence by weight category. So this is standardized for a variety of demographics, age, education, income, and so on. And simply looking at the prevalence of diabetes, for example, among obese adults and normal weight adults, it's for total diabetes about 14% and 4% for normal weight adults. Those percentages have not changed over time. Meaning if I went back and looked at 1990 data, 1980 data, those underlying prevalence rates within these body mass categories have not changed. What has changed is that we've moved 15% more of the population into the obese category. And with it, you can see the leveraging effect here, a rise in underlying diabetes prevalence. and along with that, more aggressive treatment of patients that are clinically overweight. So a lot of the story really is a public health population issue in terms of weight distribution changes, and with it, increases in the prevalence of chronic diseases that are related to weight. Also, trends in technology I've talked about that impacts both prevalence, but primarily it impacts spending per case, how much we spend to treat patients with heart disease and so on. And there's a lot of examples of this. That's a different case. Again, if most of the spending was really due to technology, that would lead us into a discussion about, are we getting value for the dollars? What are we buying with this additional expenditures? Are we getting additional years of life, better quality of life? How do we evaluate that? And again, there's a lot of new treatments that have come on the marketplace, and that, again, that's part of the story here as well that you'll hear a lot more about this afternoon. We're much more aggressively treating patients today than we did 15, 20 years ago. How many people in here have heard of this condition, metabolic syndrome? Well, for those of you who don't, metabolic syndrome is a set of cardiovascular risk factors that include individuals that are not yet diabetic, but they're pre-diabetic. They're not yet hypertensive, but they're pre-hypertensive. They have elevated triglycerides. They have abnormal cholesterol levels, or they're overweight. And if you have any three of those 5 conditions, cardiologists believe that they are synergistic and they elevate the risk of cardiovascular events occurring. As that diagnosis of cardiovascular risk factors has evolved, and it's quite controversial, certainly if you talk to endocrinologists versus cardiologists on this issue, they have different takes, I think, of it. But certainly as the definition has evolved, and as we change the definitions of metabolic syndrome, the definition, for example, of pre-diabetic has gone down over time. And as we continue to redefine disease to more aggressively do primary prevention for cardiovascular events, we pick up a substantial share of the population. 31% of the adult population, 18 and above, meets these clinical definitions. 50% of the Medicare population meet these clinical definitions. And what's happened over time is that as we have more and more individuals meeting more aggressive definitions of disease, rather than doing the usual sort of first order line of diagnosis and treatment, which is lifestyle changes, diet and exercise, the usual stuff, we're much more aggressively going right past that into treatment of the conditions with therapeutic interventions, and usually through combination therapy, meaning that we're treating individuals for multiple conditions at the same time with new therapeutic interventions, the poly pills, and so on. And those treatment rates have increased substantially over time. So just in the last 5 years, of those people who meet the metabolic syndrome definition, we're treating an additional 5 percentage point more of them. So another reason why pharmacological treatment rates are rising. The good news with this, and it's to be seen, it could very well continue to contribute to the decline in cardiovascular mortality in this country. So if you look at the data in terms of cardiovascular mortality rates, we're doing a lot better on that front. We've just recently done a little bit better on the cancer side as well. And the issue really here is whether or not these more aggressive interventions and treatments are really worth it in terms of long-term outcomes with respect to preventing cardiovascular events. That's the good news. Bad news is that in the near term, we're spending a lot more money. So if you look at the expenditure increases associated with patients that meet these clinical definitions, the amount of money being spent here is rising very dramatically over time. We're also much more aggressive in the United States, as I've tried to give you an indication of treating patients that show symptoms of disease. This is looking at hypertension patients, comparing the US, Canada, England, and Germany. And what the one that's probably the most relevant here is that if you look at the red line, the red bar, that says what percent of hypertensive patients, and again, meeting a standard definition of hypertension, they actually differ somewhat between the United States and Canada, But what percent of hypertensive patients are under medication treatment in the US versus countries in Europe? And you can see that we're much more aggressive at treating hypertensive patients with medication interventions here than they are in Canada or in England or Germany. So again, that may be a good thing. If you look at, these are related, if you look at the underlying clinical prevalence of hypertension, it has gone down over time in the United States. It is at a high level, 28%, but is certainly lower than what you see in Germany and some of these other countries where you have higher rates of untreated hypertensive patients. This is to lay this out in a little bit more detail in terms of why expenditures are going up. These are looking at age-adjusted disease treatment rates for adults 18 and above, 87 through 2003. We have the 2004 data, too, that I just haven't keyed in, and they show continued increases even between 03 and 04. And you can see the very substantial increases here. For example, in the treatment of mental disorders, rising from 5 to 17%. Again, this is largely depression, anxiety disorders, bipolar, and a variety of other disorders that aren't really related to institutions. So this is people who are not in institutions, but they're under medical management for some form of mental disorder. Obviously, the treatment of lipids through statins and other interventions has increased dramatically. Hypertension, diabetes, COPD, other pulmonary conditions, a sharp increase in asthma, particularly among kids, but you also see the same trends among adults. Arthritis, back problems, and so on. Boy, this certainly sounds like my individual with a BMI of 30 and above who is under medical management for several conditions. And in fact, if you talk to primary care physicians today, which there is certainly an abundance of them in this footage around here, really the typical profile of a 55-year-old patient coming in is a hypertensive diabetic with elevated triglycerides, bad cholesterol, got some back problems because they're overweight, may have some episodes of asthma, and they're depressed about it. And they're under medical management for all these things. So that's quite a challenging portfolio of treatment that if you're a primary care physician, to keep track of these conditions with respect to who's doing what to the patient. Most of the physicians don't have the information technology to actually monitor and see whether or not all the appropriate care is being provided. And certainly we don't have the system set up for the most part to engage the patient into self-management of their condition. So really that's, I think, going forward on the health reform piece of this, the challenge here, sort of jumping ahead of myself, is how do we rebuild a delivery model and a payment system, particularly in the Medicare program, but it's the same is true for Medicaid in the private sector, that's not treating and paying for patients that we saw in the 1960s, but is really treating and paying for patients that are coming through the doors today in 2007. It is a different patient that needs a different payment model and a different delivery model. You can see virtually all those conditions I just talked about in terms of the big prevalence increases are increases in chronic illness. The thing that's interesting about chronic disease is that by definition they have long-standing, ongoing, and largely, not entirely, but largely predictable medical care needs. So this is really quite interesting. The medical management of these patients, for the most part, is really not an insurance problem. It's really, these are patients that are sick. They have long-standing, predictable medical care needs. The issue is a medical management problem. Is how can we provide the appropriate medical interventions to these patients on a timely basis, and how can we engage them in the self-management of their care, which is a lot of the challenge here to really try to grapple with appropriately controlling and dealing with these chronic conditions. These patients are less likely to require hospitalization over time. The expenditures for these types of patients are largely on the outpatient side, ambulatory expenditures and pharmaceutical expenditures. So again, that's going to have traumatic implications, I think, on the structure of the healthcare marketplace and industry as we continue to redistribute dollars within the system that are going to follow the changes in the types of patients that are flowing through it. This is giving it a little bit more detail on exactly what's going on. This first category here, that's change in treated prevalence, what this is saying is how much of the growth in spending in arthritis patients is due to the fact that we are treating more arthritis patients, as opposed to the fact that we're spending more to treat a patient with arthritis. And if you look at that first category, for virtually all the conditions here, trauma being a notable exception, but these are the 10 conditions that are most responsible for driving healthcare expenditures up. So if you sort spending by medical condition, decompose within each condition how much of it is due to the fact that we're treating more of them, that's what this first category is doing. And you can see for virtually all of them, if you compare it to the second category, which is the change in spending per case, which is largely a technology issue, that the first category is generally much bigger than the second category. So that's, again, just drawing home the point that most of the expenditure increases by condition are really due to rises in the prevalence of disease over time. You can sort of see this too, just in terms of the implications, and I think some of the challenges with respect to managing healthcare expenditures. This is looking at the percent distribution of spending within each of these conditions. So for example, for diabetes, diabetic patients, about 19% of total spending among diabetics is on inpatient hospital care, 44% is on prescription drugs. Obviously, as you would expect, for patients that have elevated or bad cholesterol, hyperlipidemia, about 3% of spending is on inpatient hospital care, 72% is on prescription drugs. So if you can imagine 5, 10, 15 years ago, if we continue to have this evolution of patients with multiple chronic conditions, it is going to have, I think, a very dramatic impact on the shape and structure of the healthcare industry, just given the medical treatment protocols and appropriate ways of dealing with chronically ill patients over time. Much more ambulatory focus, prescription drug focus, much less focus on inpatient hospital care. I mean, it's not a surprise that over the last 20 years, through both the changing clinical characteristics of patients and changes in technology that allows us to do things more often on the outpatient side, but we have 200,000 fewer hospital beds in this country over the last 20 years. And a lot of it really is due to the fact that the clinical characteristics of patients under medical management are very different than they were 20 years ago. Implications for Medicare, this is not, to me, going to be a pretty picture. If you look at the pre-Medicare population, the 35 to 55, the 55 to 64-year-old, again, just tracing these cohorts over a 20-year period, there's a dramatic increase in the underlying prevalence of disease in each of these age cohorts that are now going to flow into Medicare, meaning that those individuals that are coming onto the Medicare program are coming into it at health states that are quite different than they were 10, 15, 20 years ago. If you look at obesity increases for people 45 to 55, just between 1997 and 2004, so this is a 7-year period, it's gone from 22 to 30%. In the last 7 years. Among those 55, it should be 64, it's gone from 22 to 29%. Disability rates in these populations have also risen, whether you measure it on an instrumental activities of daily living basis and activities of daily living basis. The share of those individuals that have one or more of those conditions who would be deemed disabled has also increased. So to me, if I'm sitting here on the sidelines watching this health policy debate evolve, Medicare has a huge stake in this population who doesn't have health insurance today, and certainly a huge stake to make sure that we're out there doing much better primary prevention, detection, and intervention today in order to see if we can't do something about the wave of baby boomers coming into the Medicare program over the next several years. These are looking at, for the pre-Medicare population, treated prevalence rates, 87, 97, and 2004. I like to look at the 97 to 2004 rates. So if you look at the treatment of hypertension, the blue line at the top has gone up from about 26% to 37%. Pulmonary conditions, mental disorders, diabetes, right across the line. Again, in this is just simply here looking at the 55 to 64-year-old group. But still, this is the individuals that are now rolling into the Medicare program And you can see the prevalence rates of disease today are much, much higher for these patients coming into Medicare than they were just 7 or 8 years ago. So again, I think it's a major challenge as we think about interventions in a way to deal with healthcare expenditures. I want to get people focused on the right sets of issues. And this, to me, is a much tougher challenge than simply trying to deal with the problem by increasing copays, deductibles, and so on. That's easy to do. The more difficult challenge is, what are we going to do about these trends? Because most of these trends are true increases in clinical disease prevalence over time. I've already mentioned this, that the clinical characteristics have changed dramatically over time. I think the challenge is, particularly in Medicare, the way we pay for and deliver health care to patients in the 21st century hasn't changed. I mean, it's still based on a 1965 health benefit model, a 1965 payment system, and for most of the country, a 1965 delivery structure. And that is an area that we need to, in terms of health reform, to me, the fundamental part of the health reform debate is really the innovation and modernization of our delivery model, our delivery system, our payment models. A lot of what we talk about health reform is on covering the uninsured, and that's important too. But that's a health financing debate. That's a political discussion. I think the more structural and more important piece is, how can we get at a delivery model that is more geared to dealing with and managing where we spend the money so we can improve the value of care, improve the quality of care, and yes, perhaps over time, if we can slow the growth in obesity, get the spending trends down. That is a healthcare reform debate that I think we all need to engage in, because it's not a partisan debate. The health financing discussion and the political discussion is a political debate. This is not. It shouldn't be. I mean, this is how do you get the appropriate clinical care to patients in the right settings at the right time? How do you appropriately pay primary care physicians to assume responsibility working with the patients to manage them and give them the tools to manage them? That's just good medicine. That's just good practice. And that shouldn't be a political issue that we disagree over. So reforms, I think, obviously, as I've stated a couple of times, I think we need to more effectively manage where we spend the money. And that's on the chronically ill patient. So we are going to have to change the way we pay for and deliver it. My sense is that the fastest way to transform the delivery model is to drive the reforms through the Medicare program and the Federal Employees Health Benefit Program. Those are programs that touch everybody in the private sector one way or another. Medicare owns the chronically ill population, yet they're probably the worst. Ironically, is a single-payer system that provides absolutely the worst care, however you want to measure it, to chronically ill patients in the country. That's because of the payment and delivery model developed in that program. Other reforms, tough ones. These aren't demand-side interventions. They're population and primary health care interventions, dealing with obesity among kids and adults. Modernizing the delivery system. I've spent some time recently in Europe dealing with the Europeans and Canadians on healthcare reform. Single-payer systems, multi-payer systems, all universal systems, all face the same delivery system challenges. Those are systems that are based on managing budgets, hospital budgets, physician budgets, primary care trust budgets, and they have not built the integrated delivery models that they're now trying to invent whole cloth, because they're seeing the same trends that we're seeing here. So it's not an insurance issue, an insurance problem per se. All of us in Europe, in the United States, and Canada are facing the same dilemma of how do you re-engineer and retool a delivery model that is just 20, 30, 40 years out of touch. So I think, again, just in closing, that there's two parts of the healthcare reform debate that I want you to focus on as you listen to candidates and other people talk about it. One is what is truly health reform, reforming how we pay for, how we deliver, how we incent patients to self-manage. What do we do in terms of primary prevention and population health care? Really dealing with the problems, the 75% spend and the rise in the prevalence of treated disease, largely obesity-driven. That's health reform. Then there's going to be a debate on health financing reform. How do we pay for and cover the uninsured? To me, in essence, that's less I don't care really how you do it. Let the states do it. There's a lot of innovation out there. Make sure the feds put up the appropriate funding to allow people to buy into health insurance. We're not going to resolve this as a national one-size-fits-all debate, but that to me is less important. The structural issues are the key thing, and I think that we can get around those in a bipartisan way. And then, yes, we'll have the political discussion on how to finance care for the uninsured. But make sure that as you talk to people or as you hear people talk about healthcare reform, that they have to have that structural change, those underpinnings as a core part of it. Because if we don't deal with the issues facing people with insurance, bringing people who are uninsured into a high-cost, administratively complex system, over time may not be affordable. And with that, I'll end, and I really appreciate the invitation to spend some time with you here today, and I look forward to the rest of the comments and presenters. So, thank you.
We have reserved plenty of time for questions for all the speakers. What we do ask is that you come to one of the microphones to pose your question, because we're recording this, and if you don't speak into one of the microphones, the people listening to it will be able to hear the response, but they won't be able to hear the question. So please, welcome. Go ahead.
Ken, hi Ken, I'll ask you a first question. I'm really struck in the presentation by the 1997 to the present changes, and I just wondered if you could say a little bit more about what's going on there. I mean, there's lots of possibilities depending on the diseases you're focused on, including some of the new quality guidelines.
If you could also say just who you are, where you're from, so that the speakers know.
I'm Bill Sage from UT Austin.
No, it's a good question, and it does vary by condition. If you look at diabetes, for example, just the 97 to 2004 increases, that's entirely due to a rise in clinical prevalence of diabetes. The ratio of treated to untreated diabetes hasn't changed in 20 years, hasn't changed in 30 years. We still only treat about 2/3 of diabetics that meet the clinical definition of diabetes. So it's not that we're treating them more, it's just we have just a persistent rise in total diabetes in the population overall and in this pre-Medicare population. The other ones, in terms of lipids and hypertension, that's commingled with metabolic syndrome. I mean, there's no question that we are reaching further down the clinical definition of disease. We're more aggressively treating asymptomatic patients today. So that's a little bit of a different take. That may be good, that may not be good. We'll have to see. Treatment of mental disorders, that's a comorbid condition largely associated with diabetes and heart disease. So we're picking that up more and more often as we have more and more diabetics and more people with cardiovascular events. So my take is that much of this is potentially modifiable, meaning that if we had actually kept obesity rates in the United States at 1987 levels, with today's technology, today's treatment interventions, today's practice patterns, and if we put into place payment and delivery models to make sure that hospitals and physicians couldn't backfill any lost patients in the system, that the base of spending would be about 15% lower. So it reduces about 1/3 of the difference between us and the Europeans right off the bat. So it's potentially a very powerful focus in terms of thinking about what are the policy tools that we can put in place to intervene.
Morning. Mark Silverstein from the Methodist Hospital Department of Public Health, and also a physician, so I very much appreciate the thoughtful presentation and trying to understand the forces that drive the increase in costs and services. I'd like to comment and tease out a little bit more the description of prevalence of treated disease versus prevalence of disease, or prevalence as a point-in-time effect of cumulative incidence of disease over an individual's lifetime. We have a tremendous advance in knowledge through NIH-funded and other investigations, and we have actually changed our definition. So we may say diabetes is diabetes, but we have a different threshold for impaired glucose tolerance versus diabetes. Similarly for hypertension, I don't know if you know, but now there's a condition called prehypertension, and watch out because we're all at risk at that. And similarly for a number of these conditions. And think about the pharmaceutical industry, which has used the science to drive conditions that once created generate a lifetime stream of revenue for the drug treatment. So restless legs, chronic fatigue, post-traumatic stress disorder, and we can go on and on. We all have our own favorite. So I'm interested in that there is a true rise in the prevalence of some conditions. There's been an increase in the workforce, increase in physician knowledge, and an increase in a pharmaceutical company driven agenda to label more. We talk about the medicalization of what was formerly normal variants. And I wonder if you've been able to tease out that increased prevalence of treated disease from what would be the increased prevalence of disease and the increased treatment of that disease.
No, that's a very thoughtful question. I appreciate that. I mean, that's a lot of, our research is sort of moving in stages here. The first one is to sort out how much of the rise is due to treated prevalence versus spending per treated case. And then the next phase of it is try to get underneath this more on how much of it is due to a rise in the true clinical incidence and prevalence, how much of it is due to changes in the likelihood that we intervene, and how much is due to the fact that we can now intervene when we couldn't intervene. And depending on the condition, those are all different. The one that I know very well is diabetes, because we've taken a standardized clinical measure looking at the NHANES data over time and going back to 1960 with this. And there's no question that both incidence and prevalence rates, age-adjusted, are rising sharply over time. And that's one, too, where the treatment rates haven't changed. The ratio of diagnosed, meaning treated diabetics to untreated diabetics, hasn't changed in 30 years. So that's an example where and that's pure driven by obesity increases. The other ones are a mixed bag. Mental disorders, we don't think that the underlying prevalence has probably changed that much, hard to tell, but certainly we've had a 20-year campaign to get people to recognize their symptoms of depression. We've had a campaign to work with primary care physicians to do a better job of detecting patients who are coming in depressed. And for better or for worse, we have new therapeutic treatment options to address issues of depression. So that's really one more of detection and technology rather than prevalence. And it's the same thing with lipids. Obviously, as statins have come on the market, the treatment rates, even over the last 5-7 years for hypertension, lipids, and so on, continue to rise. So it's a good point. We are trying to sort through these to see really how much of it is due to clinical prevalence issues versus treatment issues. Just end with this. That 30% figure, I said that about 30% of the growth in spending over the last 30 years is among the doubling of obesity. And we've tried to sort that out as how much of it is truly more numbers of people, and suppose that they're treated at 1987 levels, versus more aggressive treatment of people. And it's split about half and half. So about 15% of the growth in spending is due solely to a doubling of obesity, even if they are treated at 1987 levels. So I hope that moves in the direction of answering your question. Yeah.
Thank you so much for coming to Texas.
Oh, nice to be here.
We kept the weather nice for you, too. Great presentation. And I think it speaks to something that many of us have come to understand as being, and you pointed it out very well, the need to look at how we reduce demand and the need for primary prevention. And I would say the need for public health or a focus on population health. And I wonder to what degree we as a nation and those of us who are studying this have been able to tease out the same kind of analysis about individuals and individual diagnosis and look at populational diagnosis, the fact that we can describe it. Are there interventions that have been tried and tested and might indeed help us achieve what could be characterized as the reductions that we've seen in mortality in cardiovascular disease and in cancer with increased morbidity Is there a way to push more upstream and actually prevent those diseases, and how are we doing that? That's sort of one comment. A second comment with regards to, or question, with regards to needing to change the delivery system and a focus on primary care, and I would expect a focus on public health. How do we begin to address the workforce issues that are not in sync with how it is that we train healthcare professionals? We still train them in hospitals, and you're in the shadows of one of the more densely described, situated medical centers in the world. And yet, in the midst of that, we've got 30% uninsurance in this city and a high degree of morbidity and mortality.
No, thanks. Those are both good observations. You know, I think half the battle, let's say 90% of the battle, even more, is getting policymakers in the public sector, politicians, governors, health plan executives focused on the right problem. I mean, if you define the problem on healthcare expenditure increases as being driven by a rise in discretionary healthcare, meaning that over time we have more and more moms with more free time on their hands that are shopping their kids randomly to pediatricians, that there's an explosion of recreational colonoscopies, that there's just all kinds of crazy discretionary use of services, the answer is going to be, let's charge them a $3,000 deductible, give them an a la carte price list, and let them shop around. So, but if that's where you think the problem lies, then that's the solution. It's a demand side issue, it's benefit redesign, it's health plan incentives. If you get people refocused on what I think the issue is, the 75% expenditures on chronic disease, the rise in the prevalence of treated disease, which is a primary care population issue, which is much more difficult, that leads you to a whole different set, I think, of policy interventions. So that's the first place. We've got to get the problem defined right. Once we do that, I'm trying to find ways to get Medicare and other major players to spend the intellectual and physical capital to think about this more seriously. All the physical capital and intellectual capital is on the benefit design piece. And that's fine. There's a big role for that in the healthcare economy. I'm not bashing HSAs or anything like that. They're an important part of product offerings, and that's terrific. But we need to rebalance the equation in terms of really doing some smart thinking and making the investments into how do we really deal with prevention programs? What are best practice approaches to doing this that work? We spent virtually no money on thinking about program design, what really works and what really doesn't work. The same thing on the delivery side. This is sort of turning a big ship that has got the problem defined as just an explosion of discretionary and wasteful use, and there's certainly wasteful use in the system. But the drivers on the expenditure side aren't due to rises in discretionary spending linked with my colonoscopy and my mom with a lot of free time. It's really a different set of issues that once we get people focused on it, then I think we can get to some of those policy tools and really spend the money to think through best practice ways to do prevention. What is the best practice way of structuring a coordinated care program? We talk a lot about disease management and care coordination. There's thousands of players out there doing it. Well, most of them are awful. There are some good ones, but most of them really don't do much. They bother the physicians. There's a lot of noise coming into the doctor's office. We need to think seriously about the best practice structure of those programs. But again, those don't get the physical and intellectual time and commitment because we're still over here solving, I think, a different problem, and I think it's largely the wrong problem.
Alok Bhargava, professor of economics, University of Houston, and I work in nutritional epidemiology. I think you've made some very good points, but I think there's an emphasis missing on nutrition education and behavioral change programs. So, for example, the whole issue of diet in the West is quite critical, and we know that fiber intakes are very low. What is more is that insulin really is the missing link in this whole debate. In fact, the metabolic syndrome, if you read people like Rudolf Karks, and I have a paper in Journal of Nutrition last year. The problem is that with the rise in insulin, it's actually decreasing cholesterol absorption, so you get higher LDL levels, lower HDL levels, higher triglycerides, and so on. So I think that by the time you've reached a certain threshold and a patient is diabetic, it is inducing this metabolic syndrome. So prevention programs need to be taking place earlier. And I think it's important to assess what is the cost effectiveness of certain nutritional education programs and so on. What is more, I don't find this idea that we want to reduce obesity is a apolitical issue, because it's not. The fact is that the food industry is marketing a lot of refined foods, very energy dense, sugar dense foods. In fact, I just have a paper in Journal of Nutrition this month on added sugars. And what is more is that people like Marion Nestle, who are nutritionists, when they take on the food industry, they get sued. Of course, just the judges have more sense. They just throw those suits out of the court. But the fact is that this is not a apolitical problem, and I think it requires a fairly comprehensive approach.
No, thank you for those comments. On the nutrition side, my sense is if I could do tomorrow, what I would do is put into place a primary prevention package for everybody 45 and above, would include a health risk appraisal, do lipid panels, really get a profile of who we're dealing with. And based on where they are in a spectrum of severity, do the appropriate interventions. For most of the patients, it would be dealing with exercise, diet, and nutrition counseling. For other patients that are symptomatic, it would be a different set of interventions. But you're right. I mean, if you look at calorie intake in the United States over time, obviously it's risen as physical activity time has gone down. Most of it is processed food increases in terms of calories, everything in between breakfast, lunch, and dinner. So I think that that's really part and parcel of everything I'm talking about in terms of primary prevention. Sure, it's got to be nutrition. On the political side, I did not mean to say that was not going to be controversial. What I was saying is not a Republican or a Democratic issue. It's a controversial issue, but it's not a Republican issue and it's not a Democratic issue. And in Washington, where I spend most of my time, that's what I'm looking for. I'm looking for ways of building coalitions of Republicans and Democrats to move a healthcare reform agenda debate forward. And I think this issue of dealing with these fundamentals really is a bipartisan way of moving. It will be controversial, I grant you that. But I think it's still the right thing to do, and I think we can build a fairly major coalition to move ahead on it.
My name's Andrea, and I'm asking a question from a slightly different perspective, which is the perspective of corporate executives. And if you could just expand your ideal world to the point where you define a role and an incentive system that includes the role of corporate executives.
No, it's a good question. And for those of you who've seen the, sort of the extreme example of this on Business Week, cover this week, I mean, that's a great story about a company that's put into place a very aggressive wellness program. And for some probably too aggressive, but it's moving in the right direction. It includes for employees a health risk appraisal. It includes appropriate interventions, whether it's diet and exercise, counseling, and so on. They have a nurse on site that allows the ongoing medical management of disease, has a physician that comes in periodically. It makes it easy to manage conditions in ways that perhaps were not managed before. So that's a great example of putting into place a worksite wellness program that is more aggressively going after and trying to prevent problems before they are manifest. There's a lot of examples of companies doing this. Safeway is another example of a company that's done this. For those of you who haven't seen the Business Week article, I'd encourage you to read it. They probably go too far in terms of prohibiting some of these behaviors. But I think it's absolutely a step in the right direction. And I think you'll see more and more programs like this evolve that are worksite based, really trying to empower individuals to self-manage their conditions before they get out of control and make it easy for them to do it. You spend most of your time at work, and you need to have, I think, some place to make it easier for people to manage their diet, their exercise routines, manage their blood sugar levels, and so on.
Ken, a couple of questions. First of all, if we really think the chronic diseases are the problem, I'm not sure that just medical care is going to solve the problem. And suppose I'm just throwing out here a number of different things. So what if we tax junk foods, reduce the subsidy on corn so that it becomes more expensive to have corn syrup in our products, and require that all food producers reduce the percentage of salt that they provide in their foods down to the European levels, which would dramatically reduce our hypertension levels. So what if we do the sort of more aggressive types of regulations, not just medical care? The other thing, this is not necessarily my personal issue, but I'm sure some people think about this way. I'm not obese, and insurance is coming through the employer. So you're telling me essentially these costs are going up, and I'm paying for other people's health behaviors. And it's cutting into my wages because I'm getting a lower raise because I have to pay for other people's increase in the health insurance premiums because of their behavior. How much room is there for employers to actually get involved in this and intervene and change the behavior of what's going on?
Okay. All these are great questions. On the first one, I think that's, if you go back and look at our experience with tobacco, you're right, we attacked that issue on multiple dimensions. We taxed it. We developed new treatment interventions. So we may need to have the medical equivalent of the patch and put a beer cap on your head or something that's really can deal with this. We have a whole different change in the social view of smoking. Communities are involved. Restaurants are involved. We've changed sort of the social environment in which smoking exists. And if you were a smoker that was beamed in from 1960 to today's world, you'd been in an alternative universe. This is incredibly different in terms of the environment, the social norms, how we've shaped those norms. But it's come through education, it's come through the economics and taxing, it's come through communities, has come through public advertising and perceptions and so on. The obesity thing is not a direct comparison, all right? It's not the same thing because there is an underlying genetic component to this. There are reasons that people are overweight that have nothing to do with things that they're doing in terms of self-behavior. So it's not the same. And I want to make sure that, I'm not saying that, but there are opportunities that if you work with people and empower them and give them the opportunity to do it, the time to do it at the workplace, the time to do it at schools, that you can make a difference in terms of people's health. But you're right, this is one of those things that, you have to, start out by touching it gingerly because it's personal. It's a personal issue, and I think you've got to be cognizant of that. But I think that there are things we can do to help people and incent people positively, not negatively. I think if you incent people positively, give an example, in the state of Vermont, we did a healthcare reform plan this year. And we developed what I think are state-of-the-art chronic care disease models that are provider-based. And for patients that are elevated blood pressure, diabetes, and so on, if they enroll in a coordinated care program working with their physician, they get all the clinically recommended preventive services for free. And they get them for free because we want them to do those things. We want them to get the blood pressure exams, the periodic hemoglobin A1C tests. Those are things we want to deliver. The cost-sharing thing to me is more of a financing deterrent tool. And they also pay lower premiums. And we do the same thing with patients that are asymptomatic. So through a health risk appraisal, if we find people that are just on the cusp of this, we work with them in terms of providing them opportunities for gym memberships, do diet and exercise counseling with them. Again, trying to help people change, but we got to give them the tools. We've got to give them the time, the education, and the tools to help them do it. So I'm more of to start out with on a positive incentive side. I think it can be effective in a very positive way rather than a punitive way. Okay.
Good morning, Matthew Barnes with the Houston Endowment. I wanted to thank you first for helping my marriage. My wife does obesity research, and I've never understood anything of what she's told me until today. So I'll be able to speak with her a bit more about this. So thanks for helping my marriage.
Oh, you're welcome.
Secondly, and probably a little less personal question here is, a friend of mine here forwarded me an article by Michael Porter regarding competition in healthcare, and that you're talking about reform, and that many of the reforms that are planned or even discussed are really financing the reforms, to your point. Could you give me your reaction to Michael Porter's assertion that that competition underlies the major component of what we need to do to change how things are done, and then also the importance of having information so that we can actually understand which organizations are or which facilities are actually impacting obesity or cardiovascular care or whatever effectively. Could you give us a response or give me your thoughts about his writings about competition and information?
No, it's a good question. I think he's right in directing our attention to measuring outcomes and value in dollars spent on the right things, which is how well are we doing in either preventing people from becoming diabetic, and how well are we doing at managing diabetes. So I think that as an outcome measure, is the right way to think about this. And to have different the medical groups compete on how well they're providing all the clinically recommended care, how well they're doing at keeping people out of hospitals, and so on. I think that's the right direction. I think that the problem with it is that in his book and his thinking, he focuses it around single diseases. And the problem is that these things come in packets. It is my hypertensive diabetic with bad triglycerides, asthma, back problems, and depression. And managing that package of chronic illnesses is more complicated than I think he lets on in his thinking. But I think the direction is right, to really look at this on how well are we managing where we spend the money, how well does the Mayo Clinic do versus the Texas Heart Institute in managing patients that have congestive heart failure or different types of cardiovascular disease, and can we develop metrics for that? So I like the direction of it. Because competition as we've had it in the past is really just on at the health plan level, looking at premiums, and people can't really understand two different plans, what's the best value, because if I have diabetes and high blood pressure, it's hard for me to really tell which of these offerings is a better choice for me.
Real quick question: is the data that you've presented here somehow taking into consideration the exacerbation of these that might be occurring with these numbers as it relates to the 44 to 47 million uninsured? I'm just concerned that these numbers might just be rosy unless somehow you're trying to comprehend those people that haven't seen a doctor in 10 years, and we don't have the foggiest idea what's happening with that unique population. Because the numbers, in comparison to what we're seeing through my organization with the uninsured, we think for the uninsured, the numbers would be...
No, it's a good question. Certainly, if you look at treatment rates by health insurance status, treatment rates for uninsured patients are lower. And indeed, if you really took this to the logical conclusion, it's saying that we need to do a better job of more aggressively intervening, let's take diabetics, early on in the course of elevated blood sugar. These treated prevalence rates are obviously going to go up. And in diabetes, they'd go up by a third. For the uninsured, they go up by even more because the ratio of treated to untreated diabetes is higher among uninsured populations. But that's why, in terms of my thinking with this, the health insurance piece is important because it's a way of paying for these services. But doing the health risk appraisals, getting at the clinical profiles of patients earlier in the stage of their disease, whether they're symptomatic or asymptomatic, is really a good approach, and it's good. I think it's good medicine that we should really focus on. So again, I just encourage you as you go through the day to think about these two debates: the health reform debate, the structural changes, the changes in the delivery model, the more of a primary health care public health proposal, and then the health financing political debate, which will happen about how we get health insurance to individuals and how we pay for that. So those are two very different things that, as the course of the healthcare reform debate unfolds, I think we need to keep our eye on, and obviously my bias is on the first. So again, thank you for the wonderful questions and the wonderful facility, and I look forward to spending the rest of the day with you. So thank you.
Thank you, Ken. Our next speaker is Dana Goldman from the RAND Corporation. And Dr. Goldman is the director of the health economics program there. You may not realize it, but this is probably one of the largest and most talented group of health economists in the country, whether we're talking about think tanks or academia. It's really quite extraordinary, the research they do there. Dr. Goldman also holds the RAND chair in health economics, and has done quite a broad array of work. So he has done everything from influencing how the National Cancer Institute treats its elderly people in their cancer trials, and most lately has a great deal of research coming out on AIDS policy. But today he's here to talk about something different. He's going to talk about socioeconomic disparities in health, the role of self-management.
Thank you very much. It's a pleasure to be here, and it's hard for me to see there. It's a pleasure for me to be in a city that's as polluted as Los Angeles, and so I really appreciate that. And that's part of what I'm going to talk about today. But I'm going to start with one of the strongest empirical findings that I've seen in health, and that's health over the life cycle and its relationship to socioeconomic status. So what you see here are data. Often when we measure health and we're looking at social science surveys, we need to come up with metrics that are common across all these things. And so it turns out that if you ask people to rate their health, whether it's excellent, very good, good, fair, or poor, the answer to that one 5-point question is quite indicative of their future longevity and how much they'll spend and such. And so what these data show here is a graph from the National Health Interview Survey showing how the fraction of the population that's in fair or poor health. And you can see that health gets worse as you age, which is probably not a surprise to anyone. And you can't ask this question, by the way, of the people who died, but you can assume they're in poor health as well. It's graphed here for people. It says 0 to 11 years. It's for people with 0 to 11 years of education. And what I want to emphasize, though, is that when you start doing this at different age levels, what you find is that there's an important socioeconomic disparity. And you can see that actually the disparity is greatest at about middle age. And as you get older, the differences start to attenuate. So there's an important relationship, and these data have been presented in thousands of papers in various ways. The real question is, why do we have these health disparities? And when I look at the literature, I classify it in a few different ways. The first part is biological. So there may be genetic differences that affect people's health, and we know there are. There's also some very intriguing evidence, the Barker hypothesis, it's sometimes called, about intrauterine factors, so that what went on during pregnancy will ultimately affect not only health in early age, but can actually affect, most provocatively, outcomes much later in life. And we're learning a lot about allostatic load or stress, that when you produce stressors on animals, there's a lot of evidence from the biomedical community that when you do this with primates, with rodents and such, and even with humans, we're starting to learn that there are fundamental physiological processes that come into play that can affect future health. And then I think there's a lot of discussion of what I'll call the public health. So I mentioned the environment, and we know, wasn't joking about, if you think about what has led to the improvements in health over the last century, let's say, it wasn't whether we had a new defibrillator, and it wasn't whether we had, a drug-eluting stent. Okay, the real progress has come from public health improvements, and I'd call clean water, clean air, and pharmaceuticals, vaccines and such, and also our smoking, what we've done to reduce smoking. And so, and we've heard a lot of discussion already about obesity, and so diet clearly plays a role. And also what I'll term limited access. And the hypothesis here, and it's one that I'll talk more about, is that if you give people health insurance, it'll make them healthier, for example. And then there are actually the economic explanations, and there's some of what Vivian was talking about, which is there's work on taxes and how that affects behavior and such. But I think the key hypothesis that economists have put forward that's relevant here is not that education or socioeconomic status leads to health, but rather that health might actually lead to socioeconomic differences and that the causation goes the other way. And I'll spend a few minutes and talk about that because I think that's important for understanding what policies we should pursue. And then I'm going to put forward, I and my colleagues have put forward this as an explanation, which is self-management. So I'll talk a little bit about that. But let me just say, so when we think about what are the things up on this graph that are malleable from policy, biological factors really aren't. We can't do a lot. Although, we're doing some very interesting work at the genetic level. They found a single gene in mice that you can turn off and it will affect whether they become obese. But I don't think any of us are going to be getting that therapy anytime soon. So in the short term, I think, these factors are what they are and they're important to study, but they're not so relevant when we're talking about how we reform the healthcare system. And I'm going to put these things in a red box as well, which is probably the most controversial thing I'll say, which is if it were easy to change behavior, we would have already done it. We know obesity is bad, okay? And yet we've seen this rise and we've tried to combat it. And so changing behavior is notoriously difficult. Admittedly, if we tax McDonald's at very high rates, it'll change people's behavior, whether they go to McDonald's. But they'll do something else. And we don't know what that something else is. And so smoking, we were able to change behavior, but it took an extended effort over many, many years, and we've stalled. So I'm going to argue that actually changing behavior is very difficult to do. And actually, these are the things I want to talk about. These are the things that I think show the most promise potentially for health reform. So let me start with this economic hypothesis of reverse causation. I'm only going to say a few things about it. What does it mean? Well, basically what it means is that instead of looking at whether education causes health, let's think about whether health causes socioeconomic status to change. So take the extreme example. There's a Huntington's disease, which makes it so that many people, I think it's Huntington's disease, there's a genetic disease where people die in their mid-30s. It's a very tragic disease. They live normal lives and then suddenly they die. And if you look at rates of smoking among those people, they're incredibly high. Okay, and it's not surprising in some sense because all the consequences of smoking are mitigated. Or actually, if you look at children with asthma, you actually find that they tend, once you control for other factors, they tend to get less education. And in a way that makes sense because, I went and got a PhD. It took 23 years of my life. If my life ended at age 35, that probably wouldn't be a reasonable investment. Not that I didn't like graduate school, but there are other things you can do to actually be productive. Some would argue I'm not productive now, but that's for the question and answer point. So the point is that we would expect to see this, and poor health can also lead to diminished economic prospects. And let me talk a little bit about some of that. But the idea is that both of these stories lead to what we see in the data, which are these positive correlations between education and health or income and health. So here's some data, some work by a colleague of mine at RAND, Jim Smith, looking at the impact of the onset of a major disease on whether people work. And so these are data from the Health and Retirement Study, which is a cohort study of Americans who were aged 51 to 61 in 1992. And what I'm going to show you here are the effects of the probability that someone's working. So if you have a disease onset, in the first 2 years, there's a very high likelihood, 15 percentage point decrease in the likelihood these people will work, and it tends to accumulate so that over this 8 years of study here, there was a 27 percentage point drop in work probability. And what this does is, if you calculate out and take into account earnings and such, it leads to a $40,000 loss in income. If you add in the out-of-pocket medical expenses, you get $44,000. And so what that means is, if we look in the data, if we looked at this population and said, what's the relationship between income and health, we'd see that lower income people had worse health. And a lot of people have assumed that that income caused that health. But it actually, in this case, it actually worked the other way. That health shock, if you will, or the onset of major disease, led to a loss in income. So the policy prescription that you do in those cases is very different depending on the direction of the causation. And it turns out, though, that these effects diminish with age. And, this is all part of the story that ultimately our genes and our past behavior catches up with us. And as we get older, everyone has health shocks. And so if you look in the HEAD data, which are actually just a study of much older Americans, I think 75 plus, you see that a health shock leads to only a $10,000 loss. Now, part of that also is that we have Social Security and other systems to buttress those things when you get older. So the summary of the evidence on this is that I just want to plant the seed that this reverse causation is important, and it may diminish after age 50. So now I want to talk about access. And when we talk about access, we often talk about health insurance. And we argue that if we could give people health insurance, we could eliminate some of these health disparities. And so one way you could check this hypothesis is to see what's going on in places where people do have health insurance. So let's look at the United Kingdom, for example. Everyone has health insurance. In fact, let's not just look at the United Kingdom, let's look at the civil service in the United Kingdom. Okay, so now you've got people not only who are in a national health system, but they're also in a career path that's very similar. All of them are working for the government, which used to be an honorable profession. And so there was a Whitehall study that was done about 30 years ago that tracked how health outcomes varied. It was an epidemiological study over 25 years for people that were working in the government at a point in time. And in the UK, people tend to stay in that profession. And so you can classify people according to administrative, professional or executive, clerical, and other. And that's basically a pay grade. So and what they did in this Whitehall study is they looked at the rate of mortality. And what you see here is it says 1.8, for example, for the other. That means that over the 25-year period, they were 1.8 times more likely to die relative to the administrative group. And so even in the UK's civil service, you see these huge disparities in health, okay? And you see it in heart disease. You don't see it so much in neoplasms not related to smoking. You see it in non-neoplasms. But the bottom line from this is that giving people health insurance is not enough to eliminate disparities. So, but people say, well, that's the UK, they're different, let's talk about the United States. So we decided to look at rates of use of antihypertensive medication, which is an important determinant for cardiovascular disease outcomes. And we do it in 3 important surveys. I don't think I'll go into detail about them, but I'll just mention them. One is the Framingham Heart Study. The other is the National Ambulatory Medical Care Survey. And the third is the NHANES, or the National Health and Nutrition Examination Survey. And the reason why we went to all these studies was because the results I'm going to show you were so surprising to us, we thought we had to verify them. And so we kept going. Finally, we just believed ourselves. So what does this graph show? It's just a general use of antihypertensives in the Framingham data. And so you have a cohort that's aging over time. We have data, the Framingham data go back, it's a 50-year study. It's really quite innovative, started in the 50s. And you can see the use of antihypertensives over this period. Now, part of this is going to be due to aging of the population. But, and what you see is in the late 70s, we learned that diuretics were very successful in managing antihypertensives, and so that accounted for a lot of the use. But what happened is use of diuretics was declining over time, and in fact, what's going on is that we start introducing better drugs for treating hypertension, although some would argue they may not be better drugs in all cases, but certainly having more therapeutic agents is valuable. So you see that beta blockers came in around that time and use increased. Calcium channel blockers came into existence in the 80s and use ramped up quickly, and also ACE inhibitors, which are also useful for treating diabetes as well, and that started in the mid-80s. And we've learned a lot about under what clinical circumstances we should be using these drugs. And the question we had is, as these new drugs are introduced in the United States, do we see differential access to these drugs by education? So is it the case that only certain segments of the population are getting access to these? Now remember, we're not controlling for health insurance in this. So if it's the case that people with less education have less health insurance, and you believe that health insurance is an important determinant of access, then that should show up here when we look at the data. And in fact, if you look at this period over which calcium channel blockers were being introduced, what you see is that there are very little differences by education. They tend to basically bunch like that. And so then we went and looked at ACE inhibitors and did the same thing, and what you see again is if anything, the 9 to 11 group is an outlier, which is 9 to 11 years of education, which is very hard to explain. And these are the results of p-values for f-tests, which just is there to tell you that we actually did something other than look at lines. Okay, so then we went to the National Ambulatory Medical Care Survey, and we asked, are there differences by race in use of calcium channel blockers? And here's what, over this period, the data look like for whites, and here's what they look like for blacks. Now, there may be some, so blacks actually had higher rates of use of calcium channel blockers. There may be some clinical reason, there may be some evidence for better effectiveness for these drugs for hypertension for blacks. But if you look at ACE inhibitors as well, you see, again, a similar chart. So we're not seeing any differences by race in access to these things. So we also looked at the NHANES. I'm going to skip that. So what we see is there's no evidence of any differential adoption by education for new antihypertensives. And this is holding at the individual and at the area level. So if you look by geography, you don't see it. So one argument, though, against this is that I've happened to have picked antihypertensives which are relatively inexpensive. There are a lot of other treatments that are far more expensive. And so it's worth looking at other medical conditions. And so this gets me to self-management, albeit in a very circuitous way. So let me show you this gradient once more. Here's another view of the socioeconomic gradient. What this shows is the benefit of having a college degree. And so it's increase in the probability of good health. And the point I want to make here is that if you look at the chronically ill, you actually see that the gradient is even stronger. So once you condition on disease, it appears that everything we worried about with health disparities potentially could be even stronger once for people who have a chronic illness. And so, and there's some evidence here, I really should update this slide, albeit circumstantial, that they may even be diverging over time, and that's the part I want to talk about today. So The question is whether can adherence help explain disparities for the chronically ill. And we're developing, one of the benefits of medical progress is that we've come up with a lot of very efficacious treatments. The problem is they're incredibly complicated, and they require an understanding of medical necessity. And it's quite frustrating to doctors, I'm sure, that compliance is as low as 20% in clinical practice. So the doctor says you need to take your medication. The patient says the medication is making me sick, and the doctor says, yeah, but you got to keep taking it. And there really is a lot of internalization of the long-term benefits that needs to happen. So let me provide a view of that looking at HIV. In the mid-1990s, highly active antiretroviral therapy was first introduced. And this has been a rather dramatic development. It's turned HIV from a death sentence into a chronic disease that can be managed. But when it was first introduced, the treatment regimens were incredibly complicated. You had to take sometimes over 24 pills daily, and the medications had to be synchronized with each other, as well as you had to worry about cholesterol intake and all these other things. And so it's an incredibly complicated disease. And so what I want to look at is what adherence means for how adherence would explain the health gradient here. So here's what you see. Here is the typical chart that people would put up to show axis. And what they would say is that if you have 0 to 11 years of education, about 54% of people with HIV were actually, I should say where these data come from, sorry. In the mid-1990s, actually, we started a national probability sample at RAND. Typically, when people look at HIV, they would have some data from their clinic, or there would be some epidemiological data, but it didn't have information about a lot of detailed characteristics of the patients. So what we did is we actually went out and collected a national probability sample of people who are in care for HIV. And we used a national frame and collected these data over several years. And so the data that I'm showing are actually representative of the population in care. Excuse me. So for people who had 0 to 11 years of schooling, 54% were using HEART in our data, compared to 68% for people who had 16 or more years of schooling. But if you look actually at the fraction of people who are adhering to the therapy, you see an even greater socioeconomic gradient. So the green bars show you the axis effect, if you will. But the blue bars show you this adherence effect. And the question is, how much does adherence matter? So we went and did some, again, I want to show you that we can actually run models rather than look at charts. And so if you start adjusting for education and other factors, what these results show is the effect, the propensity to adhere, if you will. Now, this is from what's called a probit model. These coefficients are not directly interpretable, but one way to look at it is to say, well, the first thing is if it's in red, it's significant. But this bar here, the magnitude, if you're 16 plus years versus 0 to 11 years, you have a 0.3 greater propensity to adhere. Well, what does that mean? Well, that's about as big as the racial disparity in HIV. HIV adherence. So we worry a lot about race in HIV. We worry a lot about gender differences. The educational gradient is just as big. Now, the question is, how does this explain health outcomes? Well, we looked at the propensity for health to improve because our study was longitudinal. And what you find actually is that we know from clinical trials, by the way, that adherence matters for mortality. The question is, for people who live, did it matter? And what you see here is education gradient. It's in yellow. It actually, a little bit of a gradient remains. It's not significant jointly. But what really mattered for whether your health improved was whether you were using heart and adhering. That's a good sign. But if you used heart and didn't adhere, which is the interpretation of this bar here, it's actually quite pernicious because your health got worse. And actually the biology of HIV, the argument is if you don't take your medicine right, unlike with hypertension where it doesn't do anything, it actually can breed resistance that makes your disease even worse. So adherence is really important, and what we're finding is that it explains this education gradient in HIV. Now, one problem with looking at HIV in terms of is that it's, in some ways it's a good thing. There's not a lot of people who have the disease relative to the chronic illnesses that you saw that Ken was talking about. So we went and said, well, let's explore this self-management hypothesis, this adherence hypothesis for diabetes. And diabetes is the prototypical chronic illness, and as Ken pointed out, it's important to look at because it's a driver of healthcare costs. Now, we've seen from the DCCT, the Diabetes Control and Complications Trial, and the UK Prospective Diabetes Study, that the key to better outcomes for diabetes is tight glycemic control. So you've got to take care of your blood sugar. The problem is that it requires patients to continually monitor their glucose levels. So we've developed all these devices. We have blood monitoring devices, we have insulin pens, we have different medications, and they're all designed to help diabetics. And the hypothesis that we're putting forward is that these devices might be more valuable for better educated patients, but for less educated patients, they may be less useful. So we went and looked at type 2 diabetes using this health and retirement study, which I mentioned earlier is a social science survey. And if you look, when you do use epidemiological studies, it's very hard to get exactly the measures of adherence that you would like. And so we had to look at the way patients were using medication over an 8-year period. And if you look at the patients who reported having diabetes, most of which is type 2, what you see is that the people who are more educated seem to always report using oral medication, okay? And they seem to, if you see people who reported on and off patterns of cycling off medication, that's much more common in the 0 to 11 years of education group. And if you look at people who are taking insulin, you see a similar pattern. And so what we did is we classified these treatment patterns as good or poor. So good treatments involve people who we saw always reporting taking their meds, always reporting taking insulin, those who may have added insulin to an oral regimen, and poor treatments we classified as patients who stopped taking their oral meds or switching back and forth from one regimen to another. Now, these are not great data, admittedly, perfect data, I should say, but anything, any bias here would bias against us finding any effect of these behavior on outcomes. So I want to spend some time and talk about this because I think it's quite provocative in some ways. So we look at what predicts poor behavior, and these are, again, just results from what's called a probit. And what you see here is you look at education, this first column, which I've labeled no, let me do it this way, no WAIS. I'll explain that in a second. What you see is the only thing that mattered for predicting poor behavior was education. That's what the stars tell you. And there was this gradient. People who had 16 plus years, this negative coefficient means they're less likely to engage in poor behavior. So it basically affirms what I was showing you in those charts. Now, and this effect size is much bigger than any difference that you would observe for a difference in poor behavior, say racial or gender differences. Now, the HRS was useful to us because it also contained a measure of intelligence, this Wechsler Adult Intelligence Score. And there's an index on there that's supposed to get at higher level, your ability to engage in higher level reasoning. And there I have to rely on the psychologists explaining that to me because I'm not at the tail end of that distribution. But the basic idea is that it's supposed to get at your ability. It would be a measure that we thought might get at this issue of whether you can internalize the benefits of therapy. And so we put that in the regression. And what you see is in that top box, the education gradient disappeared. And actually the Wechsler score came in as significant. So I will call this nothing more than speculation. But what it suggests is one reason why we see this education gradient in adherence may have something to do with patients' ability to internalize, as I was talking about. The other thing that showed up, by the way, from this as significant was that if you got divorced, you actually more likely to engage in poor behavior for men, but for women, it's the exact opposite. So, which should not come as a shock to anyone here, I would probably surmise. Okay, so I think we've demonstrated that there's this education gradient in poor behavior, and it turns out, I'm not going to spend a lot of time on this, but it turns out that this poor behavior is the indicator for health, and when you put in education, as I did before, it doesn't seem to do things. So the point is this behavior that we're seeing actually has a lot to do with whether diabetics get worse over this 8-year period. So the summary of these results: better educated are more likely to maintain high quality treatment. It's explained by higher level reasoning, and that's a very provocative hypothesis, and higher quality treatment leads to improved general health. Now, one problem with doing, as I said, these social science data is that the disease is very heterogeneous. You know, you have type 2 diabetics for the most part, but some of them were type 1. You don't really have, you have differences in access across these systems. You have differences in quality of care, all these things that we worry about. So what we did is we went to a clinical trial. So we went to the Diabetes Control and Complications trial. And the way this trial worked is it took patients who had type 1 diabetes and it randomized them to intensive care or standard care. And you can see the differences. Intensive care, really involved a lot of self-monitoring, a lot of telephone contact, vice versa, and a lot of interaction with the care group. And then the control group, standard care, was involved in daily self-monitoring, clinic visits every 3 months, and 1 to 2 injections per day. Now, it's interesting because, in fact, if we could get everyone who has diabetes into standard care of the sort in this trial, we'd actually be doing a great job. Most people will not get this type of care. That's why we see measures as Ken was pointing out, of diabetics, with the percent who are in compliance below 50%. So even if you could get everyone into standard care, we'd be doing a good job. But here, you're going to randomize people to 2 groups. And I'm not going to spend a lot of time on the analysis, but what we found, all we did is take these, all you have to do in clinical trials is compare means, essentially. And we looked at changes in hemoglobin A1C, which is the key measure of glycemic control, over time. And we took the trial data and we cut it by education. So all we're doing is essentially what they would report in a clinical trial, but we're asking what happens by education. And so what you see here are, again, red means significant, yellow means insignificant. Now, this is another interesting thing about this clinical trial, that the people in general are kind of well educated who get into these trials. And so we actually had to look at people with a postgraduate degree to get some discrimination across education. But this is the benefit of intensive monitoring. And what you see is for this group, it's not significant. So what that says is these guys were already doing a pretty good job in standard care. Whereas for people who had only a high school degree, you actually got a clinically significant and, it turns out important, benefit from intensive monitoring. So let me conclude with, I have a few minutes, right, Vivian? 5, that's perfect. So let me conclude by saying the following. One thing that's clear is that, correlation aside, I would say the best intervention we could engage in to improve health would be to give everyone a year of education. Okay, education matters, and education matters for a lot of other things that people in other rooms in this institute probably care about as well. It matters for earnings and other outcomes. So education is important, but it's also very costly, and there's no way we're going to engage in that discussion for the healthcare reform debate. What is important about our work, I would argue, is that what it says is that you could actually get some health improvement if you would just call some of your patients every once in a while. Are you complying with therapy? And what it says is you don't have to call all of them because some of them are doing it. I would venture that most of the people in this room, you tell them to take a medication, they'll take it, or you'll take it, and I'll take it. But there are a lot of people out there, you tell them to take the medication, they get up to the counter at the pharmacy, the pharmacist says it's $20, and you say, what? I thought it was $5. No, this drug that your doctor orders is $20. So half of them don't even get the prescription. Among the ones who get the prescription, they say it's costly, they go home, and they say, you know what, I felt great before I took this pill, and now suddenly I'm getting a dry cough and all these other things. I don't need this. And so they don't take the medication. And what we're finding when we're looking at other diseases now is that intervention matters. And so it's not so much about giving people a dose of health insurance, it's about making sure that once you've identified something, you follow them as they go down the clinical pathways, which I think is coincident with what Ken was talking about, actually, about managing disease. But I would say that what we really need to do is recognize that the patient can have a lot of involvement, at least for some of these diseases. Thank you.
Hi, I'm Amy Chin from University of Houston. I have 2 questions. One is for the in most of your graphs, is the gradient understated because it's already conditional on receiving care, and so you're the differential by race, for example, if it takes a different threshold for a Black person to go to a doctor or receive medication, does that mean the gradient's understated? The second question is, you make this distinction between self-management and changing behavior. It seems like some of the things involved in improved self-management involves changes in how these people carry on their lives. So where do you draw the line? And it doesn't seem to be a simple phone call I wouldn't think a simple phone call would work for some of the more intricate types of therapy. So I'm just wondering, it could be lots of cost in doctor's time in terms of explanation. It could be communication issues training for those sorts of things become useful. I was just thinking where you draw the line between changes in behavior and improvements in self-management.
Well, the answer to your first question is categorically no, that it is not that the people are in the same system. If you look at our HIV results, those people had differential access to insurance. It turns out that it's not insurance that mattered, it's an adherence. And the same in the health and retirement study with what we did with diabetes. So for those 2 illnesses, those 2, which are not, I'm not going to generalize right now, we don't see it as insurance. It is, and if you look at the data from the UK, you see the exact same result. Everywhere you look, in places where everyone is insured, you still see these strong gradients. Now, insurance affects whether you get in the door, and it does affect management and the cost of drugs, for example. We talk about improving adherence. One of the things we can do is just mail everyone their pills every month. Why do you need to see a doctor every 3 months to get a prescription for an antihypertensive? We should just put 365 pills with every day labeled in a blister pack and mail it straight from the manufacturer. I mean, people can't get an appointment to see their doctor, so their prescription lapses, the pharmacist forgets the call. I mean, for the majority of people, they're on this medication and they're on this medication for life. So I would actually argue that in some ways, what the care system has done is created barriers to managing the, Now, what you're talking about, the other part you said is exactly right, which is you said, well, making phone calls, is that enough? Think about the homeless. They don't even have a phone. So I'm not saying this is going to solve the problem. What I'm saying is it's an easier place to start than, say, cleaning up the water or reorganizing the healthcare system. That we could reimburse modestly for management. If you, I talked to a doctor who had exactly the type of patient that Ken was talking about, a diabetic who was morbidly obese with a lot of other conditions, and he said, the best thing I can do for this guy is to get him to lose weight, but I'm not paid to do that. Well, so pay him to do that. And so you ask, how intrusive can it get? Well, compare that to, say, taxing their food or making them join a gym if they want a job. I would argue, actually, that those are more intrusive. And, if we have a home buddy system, maybe that's where you have to put your arm in a cuff in the morning. If you want to get your cup of coffee, you got to get your blood pressure checked. Is that intrusive or not? I don't know, but it might actually help manage their care.
A couple of questions, Dana. You show quite... you have to try it out first before anyone else is going to. So you've related education to better adherence. Do you have any idea whether that relationship is going to affect costs overall? So in other words, does that lead to higher healthcare expenditures, or do you actually save money in the long run?
Okay, good question. In fact, it generally turns out that, for instance, if you cover the uninsured or you get people better care, in the long run, it costs money. It doesn't save money. I wish it were true, and it would be an easy fix if we said covering the uninsured, it reduces ER use, and therefore will actually save money in the long run. All the data suggests the opposite. On the other hand, this is incredibly valuable in terms of increasing longevity, reducing functional impairments, and all the other things that we care about a lot. So it's also a tremendously effective investment. So you'll hear more about that, I'm sure, when David Cutler talks. So I do think that, I don't know what the answers are, but in general, what we do in healthcare costs a little more money and hopefully gives us a lot of health benefit. The problem is actually the stuff that costs a lot and gives us very little benefit. But I don't think that's the kind of stuff I'm talking about, But I think there's one other issue that's incredibly difficult for us to wrestle with as we think about this. Suppose we develop new technologies that only the better educated can use. So it means that a better educated person with diabetes can use this device to improve their health outcomes. Well, that's going to exacerbate health disparities, right? And, we worry about, but is that investment not worth doing? Well, that's a judgment call, but I would argue no, it's certainly an investment worth doing. If you think about these drugs, so think about we've done work on beta blockers and diuretics. Prior to that, the way you dealt with hypertension was you asked patients to engage in diet and exercise reform, and very few could. And in fact, it was the well-educated ones, if you look at the data, who actually were able to actually make those lifestyle modifications. The development of these drugs actually leveled the playing field, and you can see that disparities in hypertension actually compressed after we came up with pharmaceutical solutions. So not everyone. I live in Los Angeles, as I said, and so everyone is thin, and they all say, we don't need an obesity drug. What we need is, people, if they just eat right and, vegan, vegetarian, I can't find meat anywhere I go anymore. If people just ate right and exercised the way we do, that we'd all be thin. Well, it turns out that the well-educated, wealthy people are very good at doing that. But an obesity drug, I would argue, might actually have a benefit for the segment of the population that our interventions can't get to. If you're a single parent and you're working 2 jobs and someone's like, oh, just join a gym. I think it's easy for, I have a very flexible lifestyle, but not everyone has a flexible lifestyle. And so these interventions, you could think of them sometimes as reducing health disparities, and that's something to take into account.
Okay, and then could you just clarify how education works to change your health behavior? Because your regression with the Wechsler Index makes me think it's only smarter people who are able to get more education.
So that's we don't know, and we have a 5-year grant that we're 2 years into, and we have no results. But it's supposed to do exactly that. And it's very difficult. And so what we don't know is education a marker, as that Wechsler score result would indicate, or is there something about education that actually changes your behavior in a way that makes you can modify your future outcomes? And we don't know.
Eduardo Sanchez, University of Texas School of Public Health. What do your conclusions, or what do you think your conclusions might say about the notion of health savings accounts, consumer-directed health care, and one's ability to adhere, if you will, to what might be self-directed actions to improve one's health or to access health care, as opposed to a system where you've already been identified as needing some assistance with self-management that then is provided as a result of you having been identified?
Right, so that's an excellent question, and our results are very clear on that. First of all, we have other work on copays, which shows that people will adhere to therapy much worse when they have to pay more at the pharmacy. So what I would say about health savings accounts is, whether you think they're a good or bad idea, there should be exceptions for things we know work. And again, cheap things that are effective, like antihypertensives, are a no-brainer. You should just carve those out. It's not expensive. For instance, you could forgive generics. Not that generics are that expensive anyway, but there are a lot of things that we know are effective at managing disease, don't cost a lot, don't have to be pressure points for whether one of the criticisms of HSAs is, patients have to pay for the stuff that's good for them, they won't get it, and their health will get worse. And we actually have an article from the late 90s in JAMA about that. It turns out that that's partially right, but not fully right. But one way to get around this is to just, for the whether you're a proponent or opponent, to agree that you'll carve out things that we know are very efficacious and don't cost a lot of money. And I would argue, pharmaceutical therapy, things like test strips for diabetes, they're really not that expensive, so why make them an issue in this debate?
Tom Blocher, United Healthcare. You're making a very good point about adherence meaning better health. Do you see any changes in healthcare education, that is the education of physicians, nurses, and so on, that is reflective of this?
That's a good question. I don't know. I'd like to. And maybe when we talk about the reforms, we can think about that. Reimbursement might affect it, but not completely. We talk about pay for performance, and the fact that we're going to give a physician a 2% bump is going to affect their behavior. When at RAND, they sometimes give out bonuses that are about in that range, and I don't even know what they're for. So, so I think the promise of this is, at least the way it's implemented now, is greater than the reality.
But at least you're not aware of any training programs that have instituted programs in adherence.
No.
Hi, I'm Don Levitt. I'm a very frustrated insurance agent. Wanted to ask you, on the education part of it, I have 2 questions. On the education part of it, it looks like you're trying to understand what motivates people to adhere to a regimen. And I think, as you had mentioned before, it's difficult to really understand why people do what they do. So it looks like you're trying to stretch yourself to try to find a reason. I mean, theoretically, if everybody had a college education, we could solve the problem. But my second question is, you mentioned about the person that has 2 jobs and doesn't have the time to go to the gym. I'm wondering, do you think there is a widening income gap in this country? And if so, how much does that account for the problem?
Okay, so I need to answer both of those. The first part you said is, am I stretching myself? That this wouldn't be the first time. But I will say, what I'm trying to do is put forward a hypothesis that it's not just about giving people access to care. I'm saying once they get in is far more important, and I'll stick with that. That's the only general point. The second part about actually, what was the second?
It was the income gap, the widening
that's
income.
An excellent question.
Is it widening?
You know, I think in our results, what we often find is it's really, I focused on education because we're finding it's education, not income. And part of the reason is this reverse causation story that I was talking about. So I actually think what we'll find is that widening income inequality is not the issue. It's actually that there are people who, there's just a group and they're less educated, and that's where the action is. So I don't know the answer to that. It's a fantastic question.
So, I mean, you wouldn't even know if the income gap is widening in your assessment.
There's some debate because, you know, we've changed the way we report. So, but it is the case that it's likely that the income gap is widening. And we all know why.
Hi, Zavin Sargsyan. I'm a student at Rice. I have a somewhat specific question about the Hispanic population and adherence among that group. I've worked as an interpreter in the medical center, and I was left with a somewhat subjective impression that compliance among Hispanic patients, especially those who do have the language barrier, was very poor. So I was wondering if there's been a study that looks specifically within the population comparing bilingual Hispanic patients with those with the language barrier to see whether there is a difference in adherence. And do you think there's merit in performing such a study?
There's a lot of merit, and I suspect it's been done, and I don't know the answer to that. That's a great point. And, you know, people look at stuff like whether your physician speaks the same language as you do, and things like that. And, you know, there are a whole host, and I think that's exactly the type of research that should be done, because we want to understand. I think compliance is the key. That's what I'm saying, or at least part of the story. So we want to do those types of studies, but I can help you find where to look. It's called Google, but.
Mark Silverstein from Methodist Hospital Department of Public Health. Our conceptual frameworks are very important and powerful. It's interesting to think about a conceptual framework of intelligence as a covariate in models and social determinants of health versus the conventional years of education. But there are some interesting issues here that I think come out of this framework. We've seen now a growth in the notion of health literacy, which I kind of find attractive, although it may end up just being another way of describing a phenomenon that we characterize with education and income and occupation. But health literacy, which is also somewhat related to limited English proficiency, but not the same, may very well describe a set of abilities and skills maybe related to years of education and a variety of other conditions. And that may well translate to adherence and hence outcomes. And I wonder if you've looked at, or in this literature, whether you see any value to the thoughts about health literacy. The implications are for patients with low health literacy, the way in which we manage their care has to be different. We just can't give them an instruction or a brochure. We actually have to teach them and then have them talk back or teach back what they've learned and then work with them. So it's more expensive, labor intensive, but there's a subset of patients who may benefit from a different approach. So health literacy, I think, might be a useful concept. Have you talked about that?
Thank you.